Hi, good, excuse me, good afternoon, everyone. Welcome to another edition on this beautiful Thursday afternoon. Hopefully you'll take some time to go outside and take us with you without the video. We welcome another edition of Newton-Wellesley Medical Group Lunch and Learn. Today we're going to learn about evaluation of inguinal pain. It's all about the physical exam. We have co-presenters today, which we're excited about. Dr. Mickey Reinhorn, of course, who's been on staff with us for some time, and he's welcoming a new surgeon into his practice, Dr. Nora Fullington, who's an established laparoscopic surgeon and also will be telling us today about inguinal pain and the physical exam. Next slide, please, guys. Just to tease the forward, the next two lunch and learns, we have a nice talk about CGM, continuous glucose monitoring, coming up with Dr. Sita Raman. And then following week, we welcome Sean Rocket into the hot seat to tell us about knee pain. So we're excited about that. Just a reminder that all these talks are archived up on YouTube as well as our intranet. You can find links to any of the talks up there. Next slide. Just to remind the folks who are on the call, I remind everyone weekly about our physician and APP wellness programs, our Care Concierge program, which is free to you. Get advice for things that you need around the house in your life or other things. You can go to community.circles.com, welcome code NWH, a free full year subscription. We have our weekly virtual meditation class as well as our weekly virtual yoga class. And then Daniel Destin at the Shipley Fitness Center with our online coaching, as well as our one-year free membership, the Peloton for physicians and APPs. Feel free to contact Leland for that. And we will ask you to kind of ride with the hashtag NWH Strong for those. We had a nice ride last week on Peloton. We had, I think, around 17 or 18 folks who were riding under NWH Strong hashtag, so that was fun. Next slide. We want to also advertise or talk to remind folks as weather gets nice that our Newton-Wellesley Orthopedic Walk-In Center is open Monday through Friday, 8 to 8 for all your twisted ankles and bum knees while you're out on the basketball court or playing volleyball or running around with the kids. We're also open Saturday and Sunday. It's no appointment necessary. It is a walk-in. Avoid emergency room copays and emergency room crowds. There is a phone number there to make appointments as well. Next slide. And here's a list of the common ailments that we treat there. Next slide. I'll turn it over to Dr. Reinhorn and Dr. Fullington. Appreciate you guys coming. Thank you so much for doing this. It's all yours.
Thanks, John, for having us. I'm just going to take my mask off real briefly while I introduce myself, and then Nora Fullington. But Mickey Reinhorn, for those who don't know me, I've been at Newton-Wellesley for 15 years. I started out as a general surgeon, but for the last 3 years, really focused on hernia and pilonidal surgery. Our practice has been really busy. Thankfully, we do a couple of unique things. And so as a result of that, Nora Fullington joined the practice earlier this month, along with her physician assistant, Anna Canavan. We work as a team where every patient is seeing two providers, both a surgeon and a physician assistant. So they get a little bit more time, but with two different providers. Nora has been in practice for 5 years in the UMass system as a general surgeon. And she recognized the benefit of focusing on small number of diseases. And so she joined the practice, and we've been operating together for the last few weeks, getting acquainted, doing some quality control, making sure we do things the same way. So with that, we're going to talk to you about management of inguinal pain. I think something a lot of primary care providers see, even other specialists, and what we do for the workup.
Right.
Yeah, so these are sort of the common procedures that we see in our practice. I think John had us put sort of our contact info through the Epic referral. We're off campus down on Walnut Street, where a lot of offsite medical specialties are. We do all the different types of hernias, that mostly the ambulatory pilonidal disease, and then with Nora Fullington coming over, we're adding laparoscopic hernia surgery. And with that, if gallbladder patients need to be seen, we'll do that as well. So I'll let her take over from here.
Okay, I am Nora. I just want to put a face to a name because I think that's part of this whole thing. So hello, everybody. Thank you so much for having us, and I'm really excited to join the Newton-Wellesley system. So we just wanted to address a couple of the most common causes of groin pain, because That's really the bulk of the patients we see here. And I think really probably a very common complaint that you guys see as well. So we want to talk a little bit about the differences between hernia and groin strain, how we can diagnose patients, and then also different treatment options and what we offer at Boston Hernia. So first of all, there are some similarities in the history between inguinal hernia and groin strain. Specifically, patients generally present with discomfort in their groin. There are differences though, just based on history alone. And I would say number one is if it's associated with a bulge, that's an easy giveaway. But aside from that, also pain in the groin that seems to be getting worse with time and worse at the end of the day when patients have been up on their feet for longer periods of time. That sometimes clues us in this might be a hernia. Oftentimes when patients are lying down in supine, they're feeling better. A little bit different when it comes to groin strain, which tends to be associated with pain that specifically occurs during certain physical activities and might be actually aggravated by rolling around in bed when they're supine. Another common complaint is getting in and out of the car. That can be a little bit uncomfortable. And sometimes if it's gone on long enough, pain can improve over time. Just one other thing I want to point out with this picture, if you look at the groin strain picture on the right, it's usually caused by two potential different issues. One is actual strain of the rectus muscle and one is strain of the adductors, and both can cause a similar picture of pain.
I'll add that two parts. We feel like the history alone in a patient, I know this is a little clash, in medical school, they teach us that it's all about the history and the physical, and this really is a lot about the history and the physical, and that patients will tell us oftentimes the exact time and day they had an injury with their groin strain. So the history is really, really important, and we're happy to do that history if it's harder for you or you don't know how to differentiate it. The other part is we purposely say the word growing strain, but historically people used to call this sports hernia. And that's kind of been a misnomer, and a lot of the hernia community does not use that term at all anymore. We use core muscle injury or abdominal strain, just so that patients aren't confused that surgery is the answer. So.
And then a little bit, another tool we can use obviously is the physical exam. So when examining for a hernia, which is a little bit different than what we learned in medical school, I think, that we actually just place 4 fingers right in the groin, just to superior and lateral of the pubic bone, and have induce basically some sort of pushing in the area through a Valsalva maneuver, whether it's coughing or having the patient strain like they're having a bowel movement. And you can actually feel something bulging through fairly well with that maneuver. The other thing that we do during physical exam is test adductor strain. And we do that by this. In this picture, you can see 1 fist. Oftentimes we use 2 fists because it's sometimes a little bit easier to really get the adductors functioning. But we have a patient lie down, place 2 fists between their knees and have them try to bring their legs together. We also can have them bend their knees, do that same maneuver, and we can have them engage the core and do a partial sit-up and actually feel that lateral edge of the rectus muscle and see if patients kind of replicate the pain that they're feeling.
And going back to the physical, one of the things Nora said is we put our hands along the groin crease. We don't put our finger through the scrotum to feel for a hernia, except in rare exceptions when the history is completely consistent with a hernia. There's no muscle strain on the physical, but we don't feel a hernia in the typical way. And the reason we do that is so many patients have given me feedback over 20 years that putting a finger up the scrotum and having them cough hurts a lot. It's traumatic, and patients complain about it all the time. So it's just something that we teach our medical students, the PA students, when we have them rotate through. And I think it's a worthwhile thing to try to avoid doing.
All right, so just in general, when you see a patient who has groin strain or hear about a patient who has groin pain, we believe the first best step is for them to see their primary care physician, and a lot of the questions can sort of point to one or the other, or even just point to the fact that it's probably one of the two. It's rare that a patient would need to go to urgent care or the emergency department, but the patients who seem to have an incarcerated hernia are the ones we need to direct that way. So a patient with a very tender, newly, acutely painful bulge should go to the ER or to urgent care. In general, imaging is really not very helpful for most patients, so it's not sort of a prerequisite to seeing us by any means. And if there is a question just based on history and physical and you're really unsure, that is totally okay. We're happy to take that the next step and try to figure out what exactly is going on. Sort of broad strokes, in general hernia, we treat potentially with surgery, and strain is potentially physical therapy. So they are very different modalities, and it's important for us to know, figure out which is which. So for patients with an uncertain diagnosis, and we see so many of these type of patients that we have, maybe a more efficient approach to trying to figure out which is which. Ultrasounds can be really misleading, not so helpful, and are very user dependent. So we generally never get an ultrasound. A CAT scan can be helpful, particularly in somebody who may have a recurrent hernia, just because sometimes scar tissue in the area can be misleading on the exam, and sometimes we do need to take that step. But MRIs are another one that tend to maybe falsely inflate diagnosis of this problem of hernia, just because you see everything in such detail, and patients can have fat along their cord that can appear to be a hernia when in fact it's not. The other thing that sometimes we do for patients who remain in that unclear category of what exactly is going on is sometimes we can try physical therapy first and just see how they do. The rate of actually having an incarcerated hernia in patients with inguinal hernia is 0.2% annually. So we're not concerned about straining of the abdominal wall, allowing patients to challenge their core a little bit, even if they do have a hernia. And sometimes that's enough if it's just a groin strain.
And we talk about imaging as sort of not being great. We do order CT scans not infrequently because we get a lot of complex or recurrent hernias. We're not sure exactly what the 3D image looks like, and we'll get it as a preoperative tool. But any abdominal fat inside the inguinal canal is typically dictated or often dictated as a fat-containing inguinal hernia. And unfortunately, anyone that's overweight that has a CT scan will have fat in their inguinal canal. And so it's a very misleading thing. And what we like to do is, rather than a patient come in with a radiology diagnosis of a hernia, for us to really evaluate them and triage them, give them some advice, and order a scan if it's necessary. It's harder for us to undo a radiology finding of a hernia when we don't feel one and their symptoms are consistent with the strain. So from the triage standpoint, because we're a focused practice, I think our history and physical skills are super refined.
All right, so just wanted to talk a little bit about the different surgical approaches that we offer here. Really the most common way that hernias have been repaired in the past throughout this country are that number 2. So that's a mesh over the top of the muscle and over the top of the defect. In general, we prefer to place the mesh in a pre-peritoneal position. So that's the number 1 there. The reason being, it's kind of like patching a tire. If you patch it from the inside, it just physically makes more sense. In order to place a pre-peritoneal mesh, we have 2 different ways we can do that, open and laparoscopic, and a lot of that depends on patient factors, including BMI and other considerations. But that's fortunately something that we can tailor to each patient. Some patients can't have that and do need the anterior approach, and we can make that assessment as well. And then the other really cool thing, I think, as somebody coming into this and never having really been exposed to it before I joined here, is the no mesh Shouldice repair, which is really a highly specialized, well-developed technique that Mickey has trained in and had excellent results with, and it allows in certain patients the opportunity to have a no mesh repair that really has very good results and limited recurrence rates. So yeah.
So that the Shouldice repair is an interesting one, because 15 years ago or 20 years ago when I was in surgical residency, I was told it's an antiquated, horrible repair with really poor outcomes. You have to use mesh in everyone. And then we had a backlash of a lot of mesh lawsuits and patients doing some homework and research and surgeons doing homework and research. And even our society is saying that every surgeon should know how to do these procedures well. And I was fortunate enough to go to Toronto to scrub in and observe these cases and have one of their surgeons come to Newton-Wellesley Hospital and look over my shoulder and give me feedback. And so we've been offering this. I've had the luck of teaching this procedure through other surgeons around the country, and it's becoming more popular. It is a great repair for a small subset of patients as well, especially the ones who have been online a lot and have been really scared by lawyers, but we offer it to them and they recover pretty quickly. 91% of patients who have this repair don't take opioids after surgery, so it's not that painful. So it's a good alternative for the appropriate patient.
And speaking of not taking opioids, 95% of patients who get a pre-peritoneal mesh repair have gone through their recovery without taking any opioids, so just Tylenol and ibuprofen, which I think is a testament to the work that Mickey does through the AHSQC. So that's really been a work in progress and has been developing and improving every year, and hopefully continuing to do so. The other piece of the recovery is we generally encourage patients to limit their activity for 2 weeks. And depending on their job type, for example, if they're in public safety and need to be at full capacity, we generally encourage patients to limit their activity for a little bit longer, about 4 weeks. All right, so just talk a little bit about Boston Hernia that we have a little bit already. We're a very team focused group here. Unfortunately, joining a bunch of really collaborative people, so I'm excited about that. And I think that really adds to the clinical advantages that this practice provides. So it's really the most impressive thing, I think, and I think I can say this unabashedly because I'm joining and I'm new, but I think it's really a special place where the hernia repairs we offer here are so tailored to each individual person. Most surgeons would do one operation consistently, and that's something I would be definitely guilty of throughout my career thus far, but I'm really excited to offer more specific, more tailored options for patients. The other thing that we're able to do is avoid general anesthesia in a lot of patients, which reduces their need for postoperative pain medication and is just a quicker recovery. So that's a great option for a lot of our patients too. I think also we just have great results, lower recurrence rates, reduced postoperative pain, and quicker return to quality of life. The other thing that's very nice is the participation in the National Registry for Hernias. And through that, we're able to kind of review our outcomes and go participate in peer reviews and publish some of those outcomes. But if you go to next slide. Oh yeah, sure.
So the American Hernia Society about 7 years ago decided that the US was a little behind Europe. Europe has had hernia registries for about 25 years. And so they established what was called the AHSQC. It's just recently been rebranded as the ACHQC to Abdominal Core Health, rather than just the word hernia, they rebranded. But this is a national hernia registry that in 2017 opened up to inguinal hernia, which is the majority of what I was doing at the time. I now sit on the board of that organization, and we were looking at hernia performance across the country and collecting a robust amount of data about patient risk factors before surgery, intraoperative details, the mesh that we use. We've partnered with the FDA as a surveillance product for post-market surveillance for any new mesh product that's being put in, and we regularly meet with the FDA. It's a CMS approved registry, so it fulfills our meaningful use. So it's a really robust product. I'm lucky enough to do a lot of work with them. And we capture, this was just a snapshot of some of our, what we look at in terms of hernia recurrence and patient quality of life 6 months out from surgery. And it's a European composite score, so a lower number is better. Our data is in blue. The green is sort of the national average of hernia surgeons. So this is taking a high-level snapshot of just hernia surgeons. There's some general surgeons that are putting this data in. We're slowly growing in terms of number of patients that we're accruing and number of surgeons we're accruing. So if any surgeons out there, we'd love to have you. And so with that, I'll let you summarize.
Yeah. So the two most common causes of groin pain are hernia and strain. The key is the history and physical. We rarely order any imaging, only in specific cases. Very different modalities of treatment: physical therapy for strain and hernia for surgery for hernia. And we really try to aim for a posterior mesh when possible and avoid general anesthesia when possible. And in most patients, we can limit the use of opioids significantly after surgery through these approaches.
So I will add one thing is that we do see some patients with hip pathology. And so I think, you know, the hip exam, or sometimes we will refer to one of our orthopedic colleagues if we're not certain, or if the physical therapist gives us some feedback regarding that as well. And so I think just this, you want us, John, to summarize who we are again?
Sure.
So again, Mickey Reinhorn. I've been a general surgeon at Newton-Wellesley for 15 years. For the last 3, I've really focused on hernia and pilonidal surgery.
I'm Nora Fullington. I'm new to Newton-Wellesley. 3 weeks in, but I've spent 5 years in the UMass system and working at Milford Regional Medical Center. I'm very excited to join you all.
So thanks, you guys. There was a question in the chat box, and you know, one of the things you said at the very beginning kind of like cleared the dogma that I've been practicing for the last 20 years, which is don't put the finger up into the scrotum to feel for that hernia. So I've been doing that for 20 years. So why shouldn't I do that? And how am I going to find a hernia if I don't do that? And then the other question in the chat box was that exam for the hernia, is it done standing or sitting, or how do you measure that?
So, you know, the inguinal canal starts out as a narrow cylinder on an angle. And as the body changes, that canal becomes a little bit more of a cone and tissue can drop down. So you have to examine a patient standing up, and they have to do some sort of Valsalva maneuver. This is why sort of a CT scan or ultrasound is not as helpful, because you don't have that increased abdominal pressure, and the geometry of the inguinal canal changes when you increase the pressure. It's a dynamic part of the abdominal wall. So they have to be standing. Having said that, when you're examining the inguinal canal and you're putting a finger up, you're putting it up to try to find the tip of it. What we do is we either reduce a hernia or we just feel the pubic bone. We feel the pubic tubercle, so our hand is on it and we're in the orientation of the inguinal canal. Then we ask the patient to do Valsalva. In anyone with a BMI under 40, we can pretty easily feel a hernia that way. And we do that whether the history is consistent with a hernia or a strain. And it doesn't involve us really shoving on a spermatic cord, the testicle, and we can still elicit whether there's tissue popping out. So that's what I've evolved over the 20 years. And I'm sure we miss hernias. I mean, we evaluate well over 1,000 hernia patients a year. But if the history is consistent with it, our track record is pretty good. It's why we migrated from telemedicine early on into real visits in person, because that physical exam is so critical.
Sure. What about, I don't know, I'm sorry, I feel some echo. What about, a lot of times as primary care docs, we diagnose a hernia, and now we'll do it by holding the pubic bone as opposed to the scrotum. But patients say, well, do I need to go see Dr. Reinhorn, or can I just live with this? And like, how would you recommend we counsel our patients regarding that? I know I have my own little spiel, but I'd love to hear what you guys tell.
So I've evolved a lot in the last 18 months since COVID started. So pre-COVID, any patient that was asymptomatic or minimally symptomatic, I would have told you, you know, hold on to them, just reassure them the chance of incarceration is really low. It's 0.2%. They should just call us when they become symptomatic. And I practiced that way for 20 years. I've had surgeons sort of chastise me for sending patients away without surgery because I felt like I was not going to improve their quality of life. And so that's why I showed that quality of life slide. However, what COVID has taught me is that the progression from minimally symptomatic to symptomatic can happen pretty quickly and abruptly. And especially during COVID, our delays of getting patients into the office and into the operating room sometimes has been a couple of months from initial phone call to surgery. Just the access has been hard to get. And so now their quality of life is such that they're having trouble walking, they're not going to the gym, they're gaining weight for a couple of months. So I give patients a little bit more disclosure of, you know, you can go about your life, your quality of life is not affected. With the disclosure is, you may not get a lot of lead time and it will affect your quality of life. So if you'd like to have surgery now, we're happy to do it. And some patients still walk out without surgery and are reassured they don't need it. More patients are saying, I'll just get this taken care of when you can do it.
I think also there's the term symptomatic is going to be different for everybody. And some patients may have pain in the groin. Some patients may have just a hernia slipping in and out. And some patients may just be so panicked by knowing that it's there. And I think all of those things kind of count as symptomatic, just depending on the person. So I think it's not wrong if a person is bothered by a hernia to fix it. But it is hard to say, you know, across the board, if a patient doesn't have pain, don't have surgery. So I think, you know, there's some finesse to it and knowing your patients and maybe even just us saying it to them too might be something that can kind of bump them one way or the other and help them figure out what they want to do.
Sure. We're happy to see them and educate them about surgery and the pros and cons and risks and let them make, I mean, we really truly partner with them. We don't tell them what to do. We educate them and let them make an informed decision.
Great. Let's see. I don't see any other questions in the chat box. I want to thank you both. I want to welcome Nora to the community. Nora also was telling me that she's a full-on laparoscopic surgeon. Would be happy to take care of any gallstones or any gallbladders that you want removed as well. And I know people know Dr. Reinhorn for many years. I've been sending my patients to him since he's been here 15 years, and not to one have I heard one concern or complaint. So thank you, Mickey, for the years of service, and hope you continue to work. Yeah. So thanks, everyone. Have a great weekend. Enjoy the nice weather, and we'll see you all next week to learn about continuous glucose monitoring. Bye.
Thanks for having us.
My pleasure.